So today's topic is renal cell carcinoma. It's the most common malignant tumors of kidneys in adults. So yeah. Now this is also known as hypernephroma or Gravitt's tumor. Now it's very important to remember these terms, the synonymous terms, because sometimes what happens that if you get a short note on hypernephroma or Gravitt's tumor in exam, the biggest problem would be that if you know what is renal cell carcinoma, but unfortunately, if you don't know that it is the same thing, it's not only with the RCC, with any condition of any subject. If you're getting synonyms, then always remember the synonym terms, because sometimes if they are asked as a short note in Viva, then you should be aware, you should be able to know that yes, this is the same thing. It's usually seen, the commonest tumor of the renal tumor in childhood is Wilms tumor, but at the same way in the adults, the most common neoplasm of kidney is renal cell carcinoma, which is commonly seen in 40 to 60 years of age and slightly common in males. The etiology is multifactorial. Sometimes, in some cases, you get smoking or some occupational exposure like cadmium, hypertension, obesity. I'm just naming them. Acquired cystic renal disease and family history. Yes, this is important. If you're getting any person with renal cell carcinoma, and you should try to elicit the family history, like what you do in breast cancer. So in many cases, you find the family history is positive, or some inherited conditions like von-Hippel-Lindau disease. So we are not going in details of all these conditions. But yes, here one thing is very surprising and very striking. We should be known to your level also. That normally what we feel that smoking can cause, at the most people can understand smoking can cause bronchial cancer or lung cancer. It's not like that. Or at the most you may think oral cavity cancer can be caused because of tobacco or smoking. Smoking can lead to many malignancies of non-respiratory tract, like of urinary tract also. One is RCC, another striking example is carcinoma of bladder. Carcinoma urinary tract also, the smoking is an important etiological factor. So this is a normal thing which we know from right from our infancy in medical curriculum. This is the proximal convoluted tubule, this group of Hanley, this is DCT or distal convoluted tubule. So this RCC particularly, it arises from, because it is carcinoma, naturally it is arising from some epithelium. So the epithelium is of proximal convoluted tubule. It is the epithelium of PCT which proliferates out of control and it leads to RCC. So the origin of renal cell carcinoma is from the proximal convoluted tubule, PCT. So it is adenocarcinoma arising from proximal convoluted tubule. It usually comes in the polar region, either in upper pole or lower pole. More commonly, it is seen in upper pole. And there is early rupture of capsule. I'll explain this thing in the next slide. That what is the contour of kidney or the shape of kidney is preserved. Let us see in this slide here. You know, there is a renal capsule, then there is perinephric fat, then Girota's fascia, then paranephric fat. But here you can see that here is the RCC arising from lower pole, and in a very early stage, it seems to be quite early as compared to the other tumors. It has ruptured the capsule and it has gone into embedded in the perinephric fat. This thing doesn't happen usually in case of Wilms tumor. What happens in the Wilms tumor that there is expansion of tumor, but there is no rupture of capsule, and it leads to, in fact, eventually it leads to compression of renal parenchyma, which forms a pseudo capsule. So in Wilms tumor, one striking difference is that again it arises from poles also, but it expands, but the rupture of capsule is very late in case of Wilms tumor. But in contrast, in RCC, the renal capsule is embedded very early. Pathologically, you can see what you just saw, that I'll show in next slides also. It is solid tumor. It is yellowish, semi-transparent, and it may sometimes contain necrotic and hemorrhagic area because of the rapid growth. Sometimes it may present as a cyst only. Let me show you first this slide. This is, as I told you, The necrotic or hemorrhagic area can be seen. It's a solid tumor, glistening yellowish color. And another case, you can see here's the hemorrhage. There's a cross section and there's hemorrhagic focus. As it was told, sometimes it can present, sometimes it degenerates and leads to formation of a renal cyst. Now, this cyst is seen in USG or in CT scan. This is obviously a false cyst. It is not a true cyst. It is because of the necrosis and degeneration of tumor. So all content is liquefied. But this should be differentiated. If you are getting a patient with some cyst in the kidney, there are some criteria. We're not discussing about them at this level. But you should be aware that sometimes if a cyst is present, then it can be, very rarely it can be a presentation of a renal cell carcinoma. Mostly it is a solid tumor, but if it is because of necrosis and hemorrhage is going on, it can lead to a cystic degeneration. And microscopically, there is alternate clear and dark cells which line the blood vessel. Now, this is very important. These cells, this explains that why the spread of this tumor by blood or hematogenous route is so early. So we'll come to the microscopic view also. We already seen. This is the specimen of RCC. You can see here, it's arising from upper pole. This is kidney. This is the pelvic ileal system. This is cortex and medulla. Same thing, posterior view. Yeah, this is a microscopic view. You can see that these are the blood vessels. These are RBCs in blood vessels. And the malignant cell, they line there. Find in plenty around the blood vessels. So this explains that why spread of tumor is so early by hematogenous route. Here again I have written the synonyms. That is a Gravitt's tumor. Now pathologically, obviously it's a malignant tumor, so we are concerned with the metastasis. Let's see from which route and where it spreads. Most importantly is hematogenous route. You just saw it's around the blood vessel in microscopic view. So hematogenous mats is more common. It grows in the renal vein. We'll see in the next slides. Renal vein, it grows in the mass. So from there it can go to lungs, to the bones. I'll show that you with the help of some photographs. Here you can see in the lungs, it is the cannonball mats are there. Now, multiple mats which result in the lung. Now, they resemble like the ball of a cannon. So that's why it is called as cannonball metastasis. So cannonball mats is not only by RCC. Pulmonary mats by any source, by breast or by thyroid or from anywhere else, it will lead to a spherical metastasis. So whenever you are getting a spherical lesion in the lung, keep cannonball metastasis also in DD. In the bones, yeah. So what happens that obviously the metastasis happens more in the bones where the red bone marrow is present. So red marrow is present in adult life. In the infancy, the whole bone marrow is red, but it converts to the white marrow except for flat bones and end of long bones. Or in other words, in adults, the hematopoiesis or the blood synthesis occurs in flat bones or in the ends of long bones. So the flat bones, just to name them a few: skull, sternum, scapula, ribs, vertebrae, pelvis. These all are examples of flat bones. So here you can see the mats. You can see this skull X-ray showing metastasis. Or in the end of long bones, there is some metastasis here. Now it can present in form of a pathological fracture. We'll see in the clinical features also that sometimes it presents as pathological fracture. What is it? I'll discuss later. But the one unique thing about these mats in this bone mats that they are very vascular and they are warm and they can be pulsatile also. So very commonly, I won't say very commonly, but commonly they are mistaken as in some abscess or some other inflammatory problem. Because see, if there is a patient is presenting with a slowly growing swelling over the forehead region, and if you palpate and if you find that it is, you're feeling warm or it is pulsatile, so the warmth goes in favor of some inflammatory mass. But remember that the mets of RCC, they can give rise to pulsatile metastasis. The other very important malignancy is the follicular carcinoma of thyroid. This also gives rise to vascular and pulsatile metastasis. Now, clinically, how RCC can present to you? What are the clinical, possible clinical features? There is a classical triad of RCC. Classical triad of, whenever I say RCC, it's for renal cell carcinoma. But the students should not use the abbreviations. Hematuria, mass, and pain. Hematuria is blood in urine. Mass, there is some abdominal lump. And pain in loin region or in lumbar region. Is this triad, it is nowadays it is seen only in 10 to 15% cases. Now let me explain you that why it is so. That this is a triad of hematuria, mass, pain. There is a triad of Wilms tumor also, which is hematuria, mass, and fever. Now, what happens? Why so that it is seen nowadays only in 10 to 15%? See, the triad, this was the modality to diagnose in that era when USG, CT scan, all these investigation modalities were not available. Or if they were available, they were not easily approachable. So the presentations, usually they were very late. So in case of late presentation, because of renal cell carcinoma, there is a damage, it can lead to hematuria. If it grows in size, it can lead to mass and can lead to pain also. So if patient presents with three of them, it was usually thought that if there is a combination of hematuria, abdominal lump, and pain, then think of RCC. But nowadays what is happening, because investigations are so easily available comparatively, so nowadays the diagnosis, they are made early, and because of that, all these three, the time when it's very rare that the patient reaches to a level when the pathology advances to the mass level or to pain level. So because of that is the reason only that nowadays it is seen only in 10 to 15%. Or in other words, the late presentation, because of the advancement in investigation modalities, late presentation has been dropped down. But still, historically, you will have to remember that hematuria, mass, and pain. This is a classical triad of renal cell carcinoma. So hematuria can be the commonest. It is the commonest presenting feature, which can be intermittent. Sometimes the patient may come to you and say that okay, there was blood in urine few days ago, then again it was normal, then again there was some blood in urine. Such presentation can be there. There can be some mass. As we told you, I told you that the palpable mass can be there, and pain, there can be a dragging pain or colicky pain because of the clot is blocking ureter. So these three can be the presentation feature, but it is not essential that all case of RCC should have all these three features in them. Sometimes the presentation is only with hematuria, sometimes it is only with mass, only with pain. Sometimes there can be combination of these two or these two or these two, whatever. So you should keep your mind open for all these possibilities. Now let us see. This is only common presentation: hematuria, mass, and pain. These are the common three symptoms. But sometimes the patient presents with rare symptoms, and sometimes the symptom alone or in combination with some other symptom. So one of them is fever. Normally, when there is fever, we think of infection. But here, it is unexplained, and it is because of release of interleukin and all these pathogenic substances. And it is also called as, that is the reason that it is also called as internist tumor. RCC is also known as internist tumor. So, but the important thing is that the treatment of pyrexia is obviously the removal of tumor. The cause is tumor. So when you remove the tumor, the pyrexia will subside. But even after removing the tumor, if pyrexia is persisting, then you should think of mets. See, all metastases, it is not essential that all metastases are so huge that they are easily visible on X-ray or CT scan or USG. It's not like that. Sometimes they are so small that you will find X-ray chest is normal, bone is normal, CT scan abdomen, USG abdomen, everything is normal, but still there can be some small metastases in various organs like liver, lung, bones. So if patient is having pre-op fever and if after surgery it persists, then think of metastasis. Now, there is a series of strange symptoms. Now, there is something called as paraneoplastic syndrome when the tumor produces some hormones unrelated to that system. The one notable tumor which does so is the bronchogenic carcinoma. The other one is RCC, renal cell carcinoma. So there are see, it's a tumor of renal system. You will find it is producing hormone of hematopoietic system, hormone of calcium metabolism, like many other things. So in some cases, you may get polycythemia because tumor may sometimes produce erythropoietin. Like the patient's hemoglobin report is 16, 17, 18. It may not be good news. So the polycythemia can be a presenting feature. Varicocele, now it is a mechanical effect. On left side, if the patient is coming to you with some swelling in the scrotum and you are palpating and you are finding it to be a like bag of form appearance in that, his dilated pampiniform plexus is there. So this can be a presentation of varicocele, especially in young person which doesn't empty because that the left renal vein opens, left testicular vein opens in the left renal vein. And as I told you that sometimes the tumor may form a clot in the renal vein. So that will obstruct the drainage of left-sided testes, venous drainage. So if there is a patient with left testis is lower, left varicocele is more common, but still if you're getting a patient in which varicocele is not, it is a history short, varicocele is comparatively large. And if you ask the patient to lie down supine, you find that it is not emptying. Normally, varicocele, if you ask the patient to lie down supine, it empties. But if it is not emptying, then think of varicocele because of renal cell carcinoma. And that is the reason in such cases, you should always examine the abdomen of the patient. Sometimes there can be no hematuria, no mass, no pain. The only presentation can be caused by the varicocele. There is a strange condition called as Stauffer syndrome, which is non-metastatic hepatic dysfunction. Yes, the liver is a very favorite site for malignancies to encroach or to metastasize. But in such cases, you will find, say in such case, in a patient, you will find that SGOT, SGPT, they all are raised. So if there is any derangement of SGOT, SGPT, alkaline phosphatase, what we start think of some hepatic dysfunction. So here again, bilirubin and everything that is deranged. So this condition is called as Stauffer syndrome. Again, there is nothing to do. Liver is absolutely normal. You find that yes, in CT scan there is some renal cell carcinoma, but liver is normal, but still bilirubin is high or your SGOT, SGPT is raised. So this condition is called as Stauffer syndrome or hepatorenal syndrome. This is non-metastatic hepatic dysfunction. And the treatment, what we saw in fever here again, just do a surgery, it will be treated. After some time, all the parameters will come down if you have removed the tumor completely. There can be hypertension because of renin production. Renin can be produced by the tumor cell, so it can be a presentation as hypertension. Hypercalcemia, parathormone production. I told you that weird type of symptoms can occur. That this is the calcium metabolism, so it may produce parathormone and it may lead to hypercalcemia, and sometimes in significant numbers, in 25% cases, the presentation can be with the metastatic feature. No abdominal problem, no urinary problem, no pain, no mass, no hematuria, but patient may come to you with some metastatic feature like cough or hemoptysis. Suppose it has gone to the lungs, or pathological fracture. So pathological fracture means suppose the patient comes to history that I was walking and I fell down from 2 stairs and I got my limb fracture. So this condition may give rise to, or you may suspect some abnormal metastasis, and the source can be renal cell carcinoma. What investigations you do for? You go for CBC. Yes, you can get anemia and polycythemia both obviously not in the same case. Suppose there is hematuria and there is blood loss, large amount of blood loss is there, or there is bone mats which is impeding the RBC production. So in that case, you can get anemia. But in contrast, as we saw, in some cases there is erythropoietin is produced, and it may lead to polycythemia. Urine will show you some tumor cells. I'll show you in next slides. This is, the urine is okay, not here. The urine has got RBCs and tumor cells. X-rays are not of much use. This is the first investigation. X-ray usually we don't go because it is not very informative and it causes radiation exposure. USG is the first investigation. Obviously, we always go for that. It will give you the basic idea that yes, there is a tumor. This much is approximate size, whether it is solid or cystic, whether it is invading in renal vein or IVC, but only superficial. The moment you get anything like that, always IVP again is of not of use. Go for CT scan. CT contrast CT. I'll show you in this slide. Here you can see this is kidney, right-sided kidney. This is liver, and this is the tumor. Now it is showing you everything, that what is the size, what is the extent, where up to where it has reached. Here I would like to say these things, please do not confuse them with MATs. Normally people think that they are contrast in the portal vein or hepatic artery or hepatic vein. Because we are using an IV contrast, so contrast will go wherever there is blood. So these give rise, there is a contrast CT. If it is in non-contrast CT, and if you are finding something like that, then it is definitely abnormal, but not in contrast CT. Another case, here you can see the this is tumor, and this is a very beautiful cast of the tumor which is embedding in the renal vein. So it will show you everything, that whether it is embedding there, then what is the extent, what are the status of lymph nodes. Angiography is not routinely done. Normally, only if you are, we'll show angiography, I'll show you it later. Yeah, here it is. The angiography, you can see here, this is angiography. This is left side kidney is normal. In right side kidney, you can get a huge kidney. So it is not helpful in making the diagnosis. But if you have to go for some palliative treatment, which I will discuss in the treatment part, but for routine diagnosis, you don't need angiography. The best way is USG followed by CT scan, CECT, contrast CT. That will tell you everything. There is Robson staging system, very easy to remember. Stage 1, tumor is limited to kidney. Here you can see it's only in the kidney. Stage 2, it is invading to perinephric fat, adrenal gland, but it is not invaded the gyrotas fascia. You can see gyrotas fascia is still intact. Stage 3, naturally, go beyond it. It is extending to major vessel, to the lymph node, or it is breaching the gyrotas fascia. And finally, stage 4, if it goes everywhere all around in the perinephric fat and everywhere it is there, then it is it leads to, or it is called as stage 4. Or obviously, distant mats is there. If there is, it's in the bones or in lungs or the viscera, then it is stage 4. How you will treat it? Now, yes, the diagnosis is there, tumor is there, then. So, yes, if it is a malignancy, then definitely, first of all, usually presentation is, it's not very late, but normally when we come to know already it is a malignant tumor. So, as you know, as a principle, it doesn't mean malignant tumor. You don't have to enucleate it or remove it with some, or conservative surgery is not of much use. You should go for radical nephrectomy. You'll have to sacrifice whole kidney. So if it is inside the gyrotas fascia, you have to remove everything. Kidney, adrenal gland, then proximal ureter, to whatever extent you can remove, to the whatever level you can remove. So the whole kidney, adrenal gland, and perinephric fat, everything is removed inside, which is inside the gyrotas fascia. It is important that which approach to be used. Normally, for the renal surgeries, you always use lumbar approach. Although it is muscular, but the most important, the biggest advantage is that kidney is a retroperitoneal structure, and so you don't have to open the peritoneal cavity. But in case of malignancy and in case of trauma, tumor and trauma, in two cases, it is better if you go from anterior approach. Why? We'll talk about tumor first. So what happens in tumor? In tumor, first of all, you have to definitely, when you have to operate, suppose you've got CT scan, USG, everything is there, but when you have to operate, you have to control the renal vessels. And if you know the anatomy, from anterior to posterior, it is renal vein, renal artery, and pelvis. So if you approach from behind, first, what you will first see will be the renal pelvis. So if it is a surgery of stone, or if it is nephrectomy or pyeloplasty or whatever is that, it's good to approach from posteriorly. But if you have to control the renal vessels, which is important, then in that case, you should approach from anterior view. So because in that case, it will be easier for you to control the renal artery and renal vein. And the other advantage is that you can inspect the another viscera. Sometimes what happens, yes, CT scan is normal, liver is normal, spleen is normal, bowel is normal, but it is always better to see. If there is a very small metastasis, sometimes it can be missed or misinterpreted in the CT scan. So these are two reasons that why these two conditions, tumor and trauma, mainly because of both the things, that you have to make an early control of blood vessel, and number two, you have to inspect other viscera also, both in case of trauma as well as in tumor. So it is always better to go through anterior transperitoneal approach. And yes, as I told you that you have to, the first thing which you have before mobilizing the tumor, sometimes if you mobilize the tumor during surgery also, it can get embolized and it can go, and it can from renal vein, it can go to IVC, then from there to right atrium, then right ventricle, then pulmonary artery. So it can lead to fatal pulmonary embolism. So for that, to prevent it before mobilizing the kidney, it is important for you to control the renal vessels first. If you are getting a bilateral renal cell carcinoma, rarely the patient is so unfortunate that he has got RCC in both the kidneys, or there is only one kidney. Other kidney is either congenitally absent, or it has been already removed or donated to someone, and the patient is developing RCC in that kidney. In that case, if you do the nephrectomy, the other option, now what option the patient will be having? Either he will have to receive the kidney from someone else, or he'll be on dialysis for a long time. So instead of that, if wherever possible, if you suppose it's a polar tumor, if it's on upper pole, then the partial nephrectomy can be an option. You remove the upper pole and along with all these things, but spare at least half of the kidney. So at least the renal function will continue. So this type of surgery is called as nephron sparing surgery. It is not a microscopic surgery. Normally it sounds like a microscopic surgery, but because you are doing partial nephrectomy, you are saving some nephrons to function to produce the urine. That's why it's called as nephron sparing surgery. If vascular denervation is there, we already see that if it is already, it can sometimes go in RCC and it can go to IVC or renal vein. So in that case, you have to make the proximal control. You may have to take the help of your cardiothoracic surgeon friend also. So sometimes cardiopulmonary bypass may also be required. And as we saw just a few minutes ago that in case of the angiography, normally it is needed mainly if suppose some palliative surgery is to be done. Now what does it mean? Now suppose the patient is of old age, he has got some many moribund conditions, but his tumor is very large and the patient has got severe pain, severe hematuria. You can't operate the patient. You can't do a major surgery because of his unfitness, because of his condition. So in that case, sometimes you can either pre-operatively or sometimes as a whole also, this vessel which is feeding that kidney or that tumor, it is embolized. Now, what will happen that if it is embolized, if you put some coil or something like that, immediately the blood supply will be reduced and whole tumor or that part which was being supplied by that blood vessel will get shrinked. So if there is a big tumor, it's very difficult for you to operate. So by pre-op angiography, if you embolize, the size of tumor will reduce, so surgery will become easier for you. Or sometimes, as I told you, in advanced cases, if you don't have to do the major surgery, you can't do the major surgery in that patient, then you can go for palliative treatment also. Unfortunately, chemo and radio is not of much use in RCC. Rather than that, you go for immunotherapy, like monoclonal antibody. They can improve the outcome. Interferon, interleukin 2. These two conditions can, or these two can show some good result. Occasionally, it's very interesting that spontaneous regression may occur because of strong immune response. It's very unusual and very rare to find. Normally, if there is a tumor, especially it's a malignant tumor, it will keep on growing. It will until patient it kills the patient. But few tumors, and RCC is one of them, it can sometimes regress spontaneously. Now, it's strange, but why it is important for you to know it, because suppose you get a patient CT scan in January and it's of huge size tumor is there, and you advise the patient to go for surgery. Patient doesn't accept it. He goes away. He starts taking some alternative treatment, and the same patient comes back to you in June or July. And this time, if you go for CT scan, surprisingly you find that the size of tumor has regressed. So this is possible, not all, but it's not a rule. You cannot keep every patient on the conservative line just with the hope that it will regress spontaneously. But it is quite possible that in some cases the spontaneous regression may occur. Though you should keep it in your mind. This is one tumor which can sometimes regress spontaneously. So that's all for this lecture on renal cell carcinoma. Thank you.